Thank you so much, Dr. Wong. That was a great presentation. Lots of information for us to chew on. Looking at all of the other guidelines, it's still a somewhat confusing field, and those of us who are at the front lines of screening, like I'm a primary care physician, we have to spend a lot of time trying to tease out, some of the nuances of some of this information. And having been involved with Tom and PHEN in this for the last almost 20 years, we've gone the ups and downs of trying to deal with disparities, and screening still is, I think, the crux of where we have to figure out where to go next and how often to do this screening. So this has been a great presentation. Thank you so much. I think that we're going to look at some questions now, and I think Tom is going to sort of screen some of those. Tom.
Thank you, Dr. Carter. And I want to join you in thanking our presenters for this fantastic job that you've done in presenting the information that very helpful to patients who may be on, and very helpful, I think, to our policymakers. One of the things that that we have at PHEN focus on is trying to bring some degree of clarity to prostate cancer screening. Because what you find when you're dealing with the patient community and the public, there's a lot of confusion. And so this is one of the reasons that we wanted to have this session. We wanted to look at the guidelines, and upcoming, we'll look at some issues around active surveillance, and also what happens if we increase screening. But before we go there, we want to address some questions that have been posed. And I will take a few of these questions, and I will ask the speakers to answer these questions. And I would not. We will not answer all these questions because some are personal and some are actually will address the whole audience community here. One, are there symptoms one would notice without screening? I know that in one of our doctors, Dr. Salami, Dr. Barakas, Dr. Salami, can you answer that?
In general, prostate cancer does not present with symptoms. By the time prostate cancer is presenting with symptoms, it's probably late. And that is because it's much more advanced, it's causing a blockage, you're having difficulty urinating, you're not able to empty your bladder completely, you have a weak stream, or it's impacting erectile function, or in one of the worst case scenario, it has already spread, and then you begin to have bone pains. So because prostate cancer patients tend not to have symptoms when it's still early, that is why screening helps early detection.
Thank you. Another question is, what are some of the
May I add, Mr. Farrington, that the symptoms that people think about, like difficulty urinating, most of the time that's just enlarged prostate, and most men develop symptoms like that as they age. And so a lot of times people think, if my stream is slow or I'm waking up at night, that I must have prostate cancer, but that's really not the case. That's usually sort of a good sign. It's a sign that you have a benign condition of the prostate, not prostate cancer.
Thank you. Thank you. Next question, what are some of the indolent cancers that may show up on PSA testing?
So if I could take that, Mr. Farrington.
Thank you.
I'd be happy to. So just imagine that your PSA is elevated, and we don't know what's causing that elevation. It could be a benign condition, or it could be cancer. And so what's usually done, as you've heard, is PSA is repeated, and if it's consistently elevated, there may be imaging, there may be biomarkers, but in the end, you need a piece, typically from a biopsy of the prostate, and a pathologist looks at the cells underneath the microscope. And they, based on visual inspection, identify whether or not a cancer is present. Now, one way to try to figure out, well, is it a low risk cancer cell or is it a higher risk cancer cell? And I describe it as whether or not the cells look angrier or less angry. And the way urologists and pathologists and oncologists think about that is in terms of a Gleason score. So a Gleason score of 6, as you've heard, is a cancer that tends to be low risk. And it's important to say that in a study that compared active surveillance to radiation therapy to surgery, the survival, regardless of which option you decided as a patient, in that study remained about the same level of survival. So all of these sort of prostate cancer cells look like prostate cancer. The way we distinguish those that have a higher rate of progression and a higher risk of progression is based on the Gleason score. And a Gleason 6 is low risk. Generally, those with a Gleason 7 or 8 or higher would usually indicate or suggest or recommend treatment, whether it's based on NCCN or AUA guidance, as you've heard from our distinguished speakers.
Thank you. Thank you. How fast can cancer grow while waiting for the 2 to 4 year testing frequency?
I can try to answer that. It's very hard to answer, actually. You know, there is a concept of some cancers growing at a very slow rate, like a turtle, where you can screen every year. You may not find it picking up, or you may find it coming to a point where it's concerning very late on. And there are others that are just growing like wildfire, where even if you screen every 6 months, you might not catch it at a point where it's still treatable. And you know, I think there are cancers that could grow rapidly during that interval. However, if you look, these are sort of recommendations based on modeling studies and randomized trials where it seems that you don't compromise much on detection. Most prostate cancers are slow growing. And so a delay of 2 years or so between, you know, onset and finding it usually does not translate into a difference in outcome. It's the rare ones that are growing super fast. And in those, we may not even help people if we screen multiple times a year.
Thank you. Thank you. Can the U.S. Preventive Services Task Force recommendation improve the mortality rates in African American men? And I'm sure Dr. Wong will address that.
Yeah, thanks. That is a really important question. And I'll just say we have, you know, as you've heard, really no racial ethnic results from the European PSA trial. There's no breakout, but it's unlikely they had very many participants who were Black or African American. And in the PLCO study that was done in the United States, we had only 4% roughly of the participants, as you saw in the earlier slide. So we really don't know whether or not screening can make a difference in what we call the pinnacle of evidence, which is a randomized trial of screening versus no screening. It's really, unfortunately, the only way. I mean, we can do computer simulations, you can do what's called modeling and make estimates, but in real life, we don't know the benefits versus the harms of screening Black men with PSA. And, you know, I would think based on modern technology, you could start with the PSA and then consider all of the other additional technologies that my colleagues have mentioned as part of PSA screening as a follow-up. But again, the task force is calling and has been calling for the past 5 years for more research to understand whether or not PSA screening in Black men can make a difference in a trial.
Dr. Wong, just a quick question. You know, we found some of the flaws in the PILCO study by looking through the retrospectoscope and picking up things. Is there any possibility of sort of finding a silver lining in that, in the sense that we may start to tease out some data and find some things about, even from that 4% that we didn't know before? I mean, it may require a lot of work, but there's got to be something in there with all that data.
Finding a needle in a haystack is what I call it, Dr. Carter. And you have to dig through a lot of hay to find that needle. Yeah. And there's also from, I know from what biostatisticians say, is when you torture the data, sometimes you find things that are either false positives or false negatives. And so that would be the worry. Because when you're looking at small numbers, like 4%, a few, things that happen by chance could sway the numbers. So I actually thought about that a little bit while we were talking and thinking about that today after listening to the talks. And I hear where you're coming from. And I don't know if anybody's ever tried to do that.
Thank you. Tom?
Thank you. Dr. Wong's chart of 1,000 men is impressive. How do the other doctors involved with AUA and NCCN have to say about PSA testing? Dr. Salami, does PSA testing save lives? Dr. Wong, does PSA testing not save lives?
So I'll just say, based on the European data, clearly PSA screening saves lives. I think you can hear that consistently across all three presentations. And the sort of unanswered questions is really, for me, among Black men who we know are at increased risk for developing and dying from prostate cancer. What is the balance of benefits and harms? And what we focus on at the Preventive Services Task Force is we want to be very sure that there is benefit from screening for PSA. So we rely a lot on trials. And you could ask me, well, what about the start age? Which you will notice differed across the three presentations. And our start age relies on the two large randomized controlled trials, which are the PLCO and the European one. So the European one enrolled individuals who were 50 to 69, but very few individuals 50 to 54. And the benefit in reducing metastatic disease and in preventing deaths occurred solely in men who were 55 to 69 in the European study. The PLCO did not show any benefit. They enrolled men from 55 to 74. So our benefit, which is what caused us to change from the 2012 recommendation to the 2018, relies on the European study. And in addition to the introduction of active surveillance for those low-risk prostate cancers that help reduce the harms from overdiagnosis and overtreatment, that's what led us to get to a C for shared decision-making. And again, it doesn't mean that based on a patient's concern or a clinician's concern, that they shouldn't have a conversation about whether PSA screening should be done at a younger age or more frequently. I agree with Dr. Barakis. There are probably certain genetic disorders that place some patients with prostate cancer at some patients who have a strong family history of prostate cancer at a younger age and a first-degree relative, where it may be reasonable to do screening at a younger age or more frequently. And I think, as Dr. Salami mentioned, this is a guideline. It's based on the overall evidence, and what happens at the individual level is between a primary care clinician like yourself, Dr. Carter, and the patient who's across the table from you, and sharing your knowledge with each other And, for me, as I'm sure as you heard across these talks, that's shared decision-making where we share our professional knowledge. They share their values and preferences, which may differ across patients, which at least for me is the key determinant about when and whether to screen with PSA.
Thank you. Thank you. Dr. Slama, do you want to add to that?
Yes, just one in agreement. Yes, PSA testing saves lives. I think the challenge for us is teasing out, trying to figure out who will benefit from prostate cancer screening. And Dr. Wong mentioned that the data is not there. Yes, in terms of screening and survival benefit in Black patients, but I don't think we're going to get that kind of data because personally, I think it will be unethical to randomly assign a Black patient to screening and a Black patient not to screen. So we're not going to get that kind of data. And then the other thing I want to clarify also is oftentimes we look at survival as the only outcome. But a patient who is diagnosed with metastatic disease, yes, he may not die from prostate cancer, but he's going to be receiving systemic treatments that are toxic, that may not even have the money to pay for the treatment. So if you look at it from that perspective, screening helps with early detection and treatment, which may decrease the incidence of metastatic disease. So we're not only looking at just dying from prostate cancer, but also from the morbidity or the side effects of being diagnosed with aggressive or metastatic prostate cancer.
Yes.
I'd like
Dr.
to.
Pettigrew.
Hi, I'm really appreciative that Dr. Young's here from the U.S. Preventive Services Task Force because he has such insight. What I would like to ask is, given the fact that we may not have gold standard data, there seems to be a consensus in the data that in the years following that initial recommendation where screening really plummeted, we then began to see an increase in prostate cancer, and we began to see an increase in metastatic disease across all racial groups, but importantly in Black men. So that, in essence, almost seems like it was an experiment in nature whereby screening began to see this benefit. I'd like to get his comments on that.
Thanks so much for that really important question. I must say Dr. Crawford's presentation, as well as what you're pointing out, are really important trends. And for me, those kinds of statistics are things that open eyes and lead to questions such as the one you're asking, which is why? And did the 2012 recommendation have anything to do with that? Again, looking at the retrospectoscope, I think Dr. Carter used, is the change in metastatic disease following 2012 preceded our 2012 recommendation. And you wouldn't expect, right, a 2012 recommendation to make a dramatic change in metastatic disease. Like, you're not turning on a dime because of the long time it takes to progress. And Dr. Otis Brawley, who is the chief scientific officer at the American Cancer Society, made the same observation, from an epidemiology standpoint. For me, and I believe him, the real question is, well, why is that going on? And one possibility, and I don't know what the true answer is, but prostate cancer increases in incidence as we get older. And is this a trend that we're seeing because in general, many of us here in the United States are getting older and we're shifting as the baby boomers get older? And is that why we're detecting that increase in metastatic disease? Now, I don't know if that's the answer. I really think we need more research to understand, especially this jump that Dr. Crawford talked about. That was so unusual for me relative to other cancers because, while we know that cancer screening dropped during the pandemic, why in particular prostate cancer more so than those other three cancers that are highly prevalent? And again, for me, this calls out for more research to help us understand why. And then once we understand why, what can we do about it?
Thank you. You know, we have, let me say to our audience, we really do appreciate your engagement and your questions. However, we're not going to be able to answer all these questions. We have to move on to the next part of our program. But I do have one question here that I want to address. Maybe we can get a couple of minutes reflection on it, or maybe an answer or so in a very short period of time. And this is Dr. Bender from University of Florida, who made a statement. We recently identified in one of our state evaluations that staging of prostate cancer is no different between Black men and non-Black men, and yet the mortality is 4 times greater for Black men. While we do feel that screening improvements is important, one concern we recently brought up, your insight and want your insight on, is the treatment part. A Black man receiving less prostate cancer MRIs prior to biopsy than non-Black men. Do they receive confirmatory biopsies? Do they receive less biomarker evaluations? And so I'm gonna throw that question out to our esteemed panel. And I see Dr. Salome has stepped up.
There is data that there's, access to care is a huge component of the disparities or the inequities that we see in prostate cancer with respect to use of MRI. There's data supporting that, use of confirmatory testing. There's certainly data, supporting that. So which may in fact lead to delay in diagnosis if you're not using MRI to facilitate detection of aggressive prostate cancer. And there's also data to suggest that socioeconomic status, which plays all in part, right, into having access to treatment and quality treatment. For example, there's data to suggest that use of androgen deprivation, lupron to shut off testosterone when given radiation, is less in African Americans compared to non-Hispanic whites in certain areas. So there's certainly data to support that socioeconomic status plays a huge factor, not only in detection, but also the kind of treatment that patients receive post-diagnosis.
I'd like to definitely echo that from the standpoint of view of quality of care and the ability to access care, whether it be surgery, radiation, especially in men with intermediate to high risk disease, where they need treatment. This is where we have seen this disparity. And the thing that tends to shed the light on it is when you go to equal access settings like the VA, you see that these disparities then are dramatically reduced compared to population-based data from like a SEER database. So access is huge.
I was going to make a point about that, Curtis, that Tim Rebick, who's here, Dana in the Harvard School of Public Health, talks about the VA data and how that if everybody gets the same care, the numbers look the same for the Black men and white men in those studies. So that's interesting data.
Can I just add, this is part of our research mission, calls for research and quality improvement to eliminate disparities in access to high quality care. It only starts with the diagnosis, right? The biopsy and the Gleason score. But then, how timely is the initiation of treatment? How is the quality of the treatment that's rendered? And I'll just say, I can't speak directly to PSA and prostate cancer, but we've seen this at the U.S. Preventive Services Task Force in colon cancer treatment, timeliness of follow-up, timeliness of treatment. We've seen it in breast cancer, timeliness of follow-up biopsy after an abnormal mammogram, the quality of the treatment for the particular stage of disease, and the timeliness of that treatment. The diagnosis is only the first step. And to really eliminate these disparities, we have to follow that care pathway and look very carefully at each step of that pathway and eliminate any disparities in timeliness and quality, because everyone deserves timely, high quality follow-up and treatment.
Thank you. And so with that, thank you for your answers, and thank the audience again for your questions. We wish we had more time. But with that, Dr. Carter, I'm going to turn the program back over to you.
Thank you, Tom. So